Good afternoon. Welcome to this Thursday's Grand Rounds. Today, our Grand Rounds will be presented by Dr. Filipe Cirne. He has actually completed his residency in Brazil and fellowships in advanced echocardiography and cardio-oncology at McMaster. He holds a master's degree in cardiovascular sciences from Brazil. Currently, Dr. Cirne is an assistant professor at the Department of Medicine in the Division of Cardiology at McMaster University. He has a clinical practice with a focus on echocardiography and cardio-oncology. Today, we'll be having a talk on the topic of cardiac amyloidosis, and I'd like to welcome Dr. Cirne. Thank you very much.
Good afternoon, everyone. It's a pleasure to be here, so thank you for the invitation. Great, so let's get started. So first of all, I would like to say that we are privileged to provide care on lands that indigenous peoples have called home for thousands of years, as you know. So I would like to thank them. I have no conflicts of interest for this presentation. And as learning objectives for today's talk is evaluation of the thick heart and when to suspect amyloidosis, which will actually be the focus here. I would like to discuss with you as well a diagnostic approach to cardiac amyloid and what are the current treatment options and some of the future perspectives that we can expect down the line. So when we talk left ventricular hypertrophy, oftentimes these patients will be labeled essentially as having hypertensive cardiomyopathy, but we know that it's not that simple. And even patients with hypertension can have other conditions, which will include amyloidosis. So when we're evaluating these patients, I think first step, of course, is clinical and family history, as these can provide important clues that later and collectively with data from all the complementary testing that we have available nowadays will guide us towards diagnosis, prognosis, and even management strategies. ECG, of course, is a useful tool. Oftentimes it lacks sensitivity and specificity, but it's still helpful and it's a cheap test. So definitely to consider. Echo would be usually the next step, and echo can provide us diagnostic and prognostic information as well. And then other non-invasive imaging, like for example, cardiac MRI. And then lastly, we have biopsy and molecular or genetic analysis. Now, one of the dilemmas we sometimes face is patients that come to our offices with an abnormal echocardiogram or ECG suggestive of LVH, and who are essentially competitive athletes. And this is really a dilemma, not only from a diagnostic approach, but also from a management approach, because if we find out that these patients actually do have cardiac disease, we might just have to tell them to stop doing what they love and possibly the way they make their lives, if not now, maybe in the future. So it can be a difficult situation for sure. And in those cases, ECG can be helpful, of course, but essentially echo and oftentimes MRI will actually help us in determine if this is just the athlete's heart, meaning physiological adaptation to exercise, or if it definitely represents some sort of cardiomyopathy. And in some cases, we will even need to reassess these patients after the training, meaning that we will have to ask them to stop practicing competitively for 3 to 6 months, and then we would reassess with imaging modalities. Once physiological remodeling is ruled out, then of course we will go into determining what is the cardiomyopathy if one is present. And as you can see here on this algorithm, there are many. That's just the one I'm using, but clinical and family history, as I mentioned before, as well as ECG and echo can oftentimes be enough to narrow down our differentials and even point towards the final diagnosis. Cardiac MRI can be of added value when diagnosis is still uncertain based on echo alone. And for some infiltrative diseases, mitochondrial disorders, and mucopolysaccharidosis, um, endomyocardial biopsy and molecular genetic analysis are usually needed or oftentimes needed to confirm diagnosis and guide treatment. So some examples here would be amyloid, which is what we're going to talk today, and Fabry's disease. Now, when to consider this particular patient of having cardiac amyloid? So we have what we call the red flags. And so those would be patients who present with clinical heart failure, or patients who have atrial fibrillation, or patients who have conduction disturbances and who had a pacemaker implanted at some point. Patients with ventricular arrhythmias would also be of concern for amyloid. And then in terms of musculoskeletal symptoms and syndromes that these patients might present with are carpal tunnel syndrome, especially when bilateral, back pain or lumbar spinal stenosis, ruptured distal biceps tendon, shoulder, knee, and hip, prior history of shoulder, knee, and hip pain or surgery, and trigger finger. These patients oftentimes will have polyneuropathy and autonomic dysfunction, which can manifest as orthostatic hypertension or even intolerance to blood pressure meds, here including especially ACE inhibitors and beta blockers, which are oftentimes medications used for the heart failure itself, especially in the reduced ejection fraction realm. They can also have GI autonomic dysfunction, which can manifest as chronic diarrhea, constipation, weight loss, and even erectile dysfunction. Nephrotic syndrome and kidney dysfunction can also be seen if there is infiltration of that organ, and especially for amyloid patients, not as common as thought historically, but we can still sometimes see patients with macroglossia, hepatomegaly, and periorbital purpura, but that happens in around 15 to 10% of the patients only. Now, if we go to pathophysiology, here you can see that these are actually very different diseases from one another when we talk about AL amyloid and ATTR amyloid. So in AL, it's a plasma cell dyscrasia that produces excess immune globulin light chains, kappa or lambda usually, and those proteins misfold and they form the amyloid fibril, which is actually what infiltrates the organs. Whereas for ATTR, let's say the protein factory is in the liver. It can be wild type or genetic from a mutation, and essentially the liver will produce this tetrameric form of TTR that becomes a misfolder monomer, and then this will form the TTR proteins, let's say, that will infiltrate the organs. So let's say the origin of the abnormal proteins differ quite significantly, and that's why you will see later that even though manifestations oftentimes overlap, the treatment is very different. With regards to epidemiology, as you all probably know, it's more common in the elderly population. That being said, we do see some cases of amyloid in patients in their 40s or even 30s, but although less common, you can still see that, and seemingly also more common in male patients. With regards to clinical presentation, when we talk about AL and the ATTR forms, in spite of some differences, you will see that heart failure, neuropathy, and musculoskeletal syndromes are common features of both AL and ATTR. And interestingly, you will see that atrial fibrillation, which comes usually from atrial infiltration, can actually precede heart failure syndrome from several years. Now, this is something very important, and I think Oftentimes, if you're not very careful with this, we can easily underdiagnose amyloid or even overdiagnose, and that, as you can imagine, will have prognostic implications and also management implications. So whenever we suspect amyloidosis, first step is to rule out AL amyloid, because that's a medical emergency. Because if we don't treat these patients very early, and that will usually involve referral to a hematologist, which will prescribe chemotherapy and or stem cell transplant for these patients. So we need to rule that out first, and the way we do that is by ordering free light chain, and then we will assess the ratio between the kappa and lambda. And we should also order serum and urinary electrophoresis with immune fixation, because without immune fixation, we cannot know if this is truly amyloid or not. If those are positive, then we will definitely need a biopsy and tissue, and we use the red Congo staining to confirm that. And then, of course, some other tests might be helpful, like, for example, NT-proBNP and troponin, especially for staging, which is something I'm going to talk later. And then other tests to assess for other organs involvement, like, for example, liver and kidney. Okay, so that's essentially it. If your initial biopsy is negative, but you still have a high suspicion for AL amyloid, it's not unreasonable to repeat a biopsy. Just something to keep in mind. If the screening is negative, well, AL amyloidosis is unlikely, very unlikely at least. And then in those cases, historically, those patients would go for biopsy, but now we have the bone scans, which we're also going to talk later. So you can order those, and those are available to us here from Nuclear Medicine. And essentially, if you have a positive or strongly positive bone scan, then we're essentially dealing with ATTR amyloid. Now, some caveats I wanted to highlight here is that the essentially the screening is with regards to AL amyloid is necessary but not sufficient. And again, we always need biopsy, and that is because if you have free light chain or serum urinary electrophoresis tests that are positive, some of the differentials here will be MGUS, indolent B-cell lymphoma, or Waldenström microglobulinemia. Sorry. So that's why biopsy is definitely needed. And in those tests also, an M spike cannot be identified on serum protein electrophoresis in up to 30% of patients with AL amyloid. So that's why we should always also order the urinary protein electrophoresis and the serum free light chains. With regards to biopsy, a combination of the abdominal fat and bone marrow biopsies will identify essentially 85% of patients with AL amyloidosis. So good diagnostic yield, but not perfect, as you can see. And another very important point is do not perform the bone scans if monoclonal gammopathy is present. And I see that oftentimes being ordered in parallel with the AL amyloid screening, and I find that an error and a waste of resources, because even though initially it was thought that these tests were specific for ATTR amyloid, now we have data showing that 10 to 25% of patients with AL amyloid will essentially have a positive bone scan. And that bone scan can be even grade 2 or 3 from the Perugini classifications, meaning that we cannot essentially differentiate that if we don't have the AL amyloid ruled out first. Now, let's talk about ECG a little bit. So here I'm showing you a classic ECG of low voltage and pseudo-infarct patterns that are associated with amyloid. That being said, this usually reflects advanced cardiac disease and independently predicts cardiovascular death. So even though it can be somewhat specific, it's not as sensitive, especially in earlier stages of the disease. And not necessarily we will see the so-called low voltage pattern. More commonly, what we see is just a mass voltage dissociation between ECG and the imaging modalities, more commonly echo. So in this study here, you can see that in AL amyloid, this is a contemporary study, only 55% of the patients were actually shown to have a low voltage on ECG, whereas for ATTR, that was even less common. So only 35% of the patients had those classic ECG abnormalities. But when present, this is definitely an independent predictor of probability because, again, it probably suggests advanced disease. And now we know that prevalence depends on definitions used and criteria used, as seen here on this ROC curve from a recent study as well. And actually, a minority of patients can show LVH on ECG. So whenever you're suspecting amyloid, don't rely solely on ECG to rule in or rule out the disease. With regards to arrhythmias, we can see the atrial fibrillation, which is a common feature, as I mentioned before. We can also see conduction disturbances, as seen here in a complete heart block, and ventricular arrhythmias, like, for example, ventricular tachycardia, can be seen. Atrial fibrillation is present in up to 70% of these patients and is often highly symptomatic and poorly tolerated. Conduction diseases are also common and most often involve the His-Purkinje system, and placement of pacemaker is often required. That being said, we don't know the value of prophylactic permanent pacemaker implantation as advocated by some experts in the field. And placement of ICDs, whether for primary or secondary prevention, has also not been shown to improve outcomes in this population. Another, let's say, worrisome complication that we see on amyloid patients, regardless of having atrial fibrillation or not, is intracardiac thrombus and embolic events, especially stroke. So as you can see here on this was an amyloid patient with, this patient had a fib, but also shown to have a left atrial appendage thrombus here on this TAE. So these patients are at a high risk of intracardiac thrombus, regardless of their SHADS-VASc score, if in a fib, but again, it can happen even in sinus rhythm because they can have advanced atrial myopathy from the amyloid protein infiltration.
Okay.
So there was this study assessing outcomes related to direct current cardioversion of atrial arrhythmias in adults with cardiac amyloidosis. And interestingly, you can see here that in patients with amyloid, the rates of cancellation of the procedure was higher than controls. So 88% against 77% in controls. And the rate of complications was also higher, 14% versus 2%, and those included mainly ventricular arrhythmias, bradycardia requiring pacing, and even stroke. And here you can see the reasons for canceling planned cardioversion, and you see that the majority of patients with amyloid had the procedure canceled because of intracardiac thrombus found in the pre-cardioversion TAE. And that was seen in 81% of the cancellations, whereas for controls, only a quarter of the patients would have intracardiac thrombi, precluding cardioversion. So caution and TE are definitely recommended, even if anticoagulation is therapeutic in patients with amyloidosis. I don't know if this will play or not, but let's give it a try. So I have two echocardiograms for two patients. And I don't know if someone is bold enough to try and see which one has amyloid and which one has not. I'll give a couple seconds to see if somebody jumps in.
Mm-hmm.
I can't see the chat. I don't know because I'm in presentation mode, but anyway, both of these patients have amyloidosis. So the left one has a phenotype more consistent with dilated cardiomyopathy, whereas the one on the right is the classic echo appearance of amyloid with a very thick myocardium, thick and bright, and significant diastolic dysfunction, whereas systolic function is still preserved at this point. And that tells us that my amyloid is not always about thickness and brightness, and we can see patients that will not present the classic way on echo, essentially. And although echocardiography is useful for both diagnosis and monitoring of heart involvement, the overlap of echocardiographic features among multiple diseases makes echocardiography poorly suited to rule out the diagnosis oftentimes. And so last, I would say, final message is amyloid can be atypical, heterogeneous, and complex. So even though echocardiography is a powerful tool, don't rely solely on that, especially if your initial suspicion is high. Now, talking a little bit more about echo, some of the, let's say, typical features will be, of course, LVH, also RVH. That's an important clue. These patients oftentimes will have advanced diastolic dysfunction, biatrial dilatation, pericardial and pleural effusions, and the strain pattern, which everybody knows, and that is the apical sparing pattern. So with that being said, again, especially in early disease, echocardiography lacks specificity to precisely distinguish amyloid from non-amyloid infiltrative diseases or hypertrophic cardiomyopathy. An interestingly finding from recent studies is that LV thickness and mass are higher in patients with ATTR wild-type cardiac amyloidosis, which likely reflects longer duration of amyloid accumulation compared with AL or the ATTR mutated patients. The typical increased myocardial echogenicity described historically in cardiac amyloid is neither specific nor sensitive, so don't trust on that when you see it or when you don't see it. And grade 3 diastolic dysfunction or a restrictive pattern is only seen in advanced disease, so not a very sensitive finding. And the apical sparing, interestingly, although historically thought to be a very specific echocardiographic feature of amyloid, can be seen with other diseases. Sensitivity is around 93% and specificity 82%, so a somewhat good diagnostic yield, but still not perfect. So another frequent or more frequent association we see nowadays is between aortic stenosis and amyloidosis. So in this study, it was shown that actually on a population of all comers with calcific aortic stenosis, about 6% of those patients with more than 65 years old actually had ATTR wild type amyloidosis, which was initially labeled as senile amyloidosis. And those with amyloid definitely have a worse survival regardless of the presence of the aortic stenosis. So in this here, you can see that at a median follow-up of around 2.3 years, half of the patients with wild-type ATTR amyloid died compared with around 8% in the control population. In this other study, interestingly, in patients undergoing TAVR, we see that about around 16% of these patients will have ATTR amyloid. So that's a significant number of patients referred to TAVR, especially if we think that nowadays most of the patients with isolated aortic stenosis will be referred to TAVR and not SAVR. And you can see here that one of the clues to think of amyloidosis in this population is that more often than not, they do have hypertrophy, whereas patients without amyloid but severe aortic stenosis can have normal left ventricular mass. And patients with amyloid more often than not will have concentric hypertrophy rather than eccentric hypertrophy. Now I'm just showing you from the same study the assessment of GLS. So as you can see, the global longitudinal strain was definitely lower in the amyloid patients, but interestingly, the apical sparing pattern was essentially the same in both groups. So the presence of that string visual was the same, so it could not differentiate between those patients. And this reinforces the idea that absence of apical sparing, or the cherry on top, as some prefer to call it, does not rule out amyloid for sure. And so one of the possible explanations for this is that the stress and afterload imposed on the ventricle by the severe stenotic valve masks the sparing of apical strain that is otherwise detected in a patient with pure ATTR amyloid with no aortic stenosis. So from these studies, we gather that some of the features to elevate suspicion for ATTR in severe symptomatic AS are older adult male patients, patients with low flow, low gradient AS, patients with lower systolic blood pressure than the average of patients with aortic stenosis, elevated BNP, low ECG voltage to mass ratio, increased QRS duration, presence of conduction disturbances, including right bundle branch block, patients with mid-range ejection, heart failure with mid-range ejection fraction, LVH that is disproportional, especially if it's thought to be disproportional or not improving after the TAVR procedure, patients with left atrial enlargement, patients with advanced diastolic dysfunction, patients with impaired GLS, but global GLS don't rely solely on the apical sparing pattern, and patients with low mitral S wave. And of course, if we take each of these parameters in isolation, our diagnostic yield will be lower. So it's usually a multi-parametric approach, as you know, and the more criteria, more of these criteria you have, the higher the likelihood of you having amyloid. So now I'm going to talk a little bit about MRI, which is a powerful tool, although to be honest with you, I think this is less often used these days. The way I see MRI for amyloid is in a patient in which we're unsure based on echo, clinical features, and ECG, and we don't have easy access to biopsy, or the patient doesn't want a biopsy, and we will see some referrals of patients who received MRI for a non-specific cardiomyopathy, and then the MRI was suggestive of amyloid. Those are usually the referrals we get in patients with MRI. But again, now with the use or with the availability of the bone scans is less often used. So techniques here will be delayed gadolinium enhancement, which is usually diffuse and with transmurality reflecting disease stage. So the more transmural, the more advanced the disease is. So the classical MRI pattern of diffuse subendocardial LGE is usually seen in early disease, whereas in later stages, the whole myocardium will be essentially replaced by the amyloid proteins. Another important clue is difficulty nulling the myocardium or myocardial nulling before blood flow, and that is strongly suggestive of cardiac amyloidosis with a virtual sensitivity of 100%. And then other protocols can be used like T1 or T2 weighted imaging sequences, T1 mapping, and especially nowadays, extracellular volume is a very useful tool both for diagnostic purposes and also for prognostication. Again, the caveat here is that these features may not necessarily be specific for amyloid, so one should always evaluate this collectively with all the other data you have from clinical history, family history, and other tests that you have available. Although cardiac MRI is sensitive for distinguishing AL from other cardiomyopathies, it may not be suggestive in patients with early involvement of the heart by AL amyloid, as I said, because these patients can actually have absence of late gadolinium enhancement. And the other limitation that you might have when referring patients for MRI is if they have kidney dysfunction, especially if the eGFR is less than 30, these patients essentially cannot receive gadolinium because of the risk of systemic fibrosis. So also something to be careful about. And then a breakthrough in the management of patients with amyloidosis was actually the establishment of bone scan through SPECT in diagnosis these conditions. So it's a very well-established method nowadays for ATTR especially, and it can actually avoid biopsies in those cases. And a hard to contralateral ratio of 1.3 or grade 2 and 3, as shown here in this classification, are virtually diagnostic of ATTR. But again, I would like to highlight that it can be positive in AL, as mentioned before. 20% of AL patients will actually have grade 2 or 3 on this classification. So always rule out AL amyloid first. Sounds good. Let's move forward. So some of the limitations of this test is that they can be false positive in other types of amyloidosis, including AL, as I mentioned. And they can also be positive in patients with, for example, hydroxychloroquine cardiotoxicity, which can also show an apical sparing pattern on echo. And this less common, I should say, but these scans can also be false negative, especially in very mild disease or if problems have occurred with a technique acquisition. And then cardiac PET is a new modality, I should say, still being tested for these patients. And it essentially has the ability, it seems like, from current data to image cardiac and systemic AL amyloid deposits throughout the whole body. Currently not being used in clinical practice. And it's also being investigated for early detection, quantitation, and assessment of response to therapy. Some remarks on biopsy. So it'll always be needed for confirming AL amyloid. That can be from fat pad, that can be from lips, and oftentimes it will be from bone marrow, which is what the hematologists would usually do. Interestingly, there are cases in the literature of patients who were referred to an amyloid clinic or an amyloid specialist because of fat biopsies that were positive for amyloid. And it's not like they didn't have amyloid, but it's just that those were focal amyloidomas. So it was not a systemic disease. And those can happen, for example, in response to chronic insulin therapy. And the last thing I wanted to mention here is that if you have a patient in which there is a suspicion for amyloidosis and you don't have a biopsy done yet, particularly after the suspicion was raised, you can always go back to patient medical history and see if they had any procedures done before, like, for example, prostatectomies or vitrectomies, because there are cases in the literature showing that you can sometimes find amyloid deposits in those places. And so essentially, if you do find that, if you go back and find those, you can essentially spare another biopsy for that particular patient. So AL amyloid is a medical emergency, and that is because up to 20% of the patients die in the first 6 months, and 43% can die in the first year. And the reason why I think this talk is important is because median survival essentially depends on the cardiac stage of the disease at diagnosis. So if we look at the survival trends in amyloid, you will see that well, essentially, delayed diagnosis makes a huge difference for these patients, as you can see here. So these patients are essentially dying until a diagnosis is made. So whenever that there is a suspicion, we need to be fast, at least in ruling out AL. And then if that's ruled out and there's still suspicion, well, then we have some more time to investigate for ATTR, as it is less deadly. But essentially, what seemed to change this patient's prognosis significantly over time was the advent of stem cell transplant, of course, for the patients that are eligible, as you can see here. And then for ATTR, at least until 2013, it seems like the prognosis was similar if you look historically at 4 different cohorts as seen here. So these patients were still dying significantly in a significant rate. But that is probably because until this, we didn't have the disease modifying agents tested and available, essentially. Now, it's also important to mention that we have many staging systems for these patients. The one that is more commonly accepted and used nowadays is the one from the Mayo Clinic. And here again, you can see that cardiac damage plays an important role here, assessed through troponin and NT-proBNP. And you can see if both troponin and BNP are abnormal, the 5-year survival is 14 to 28% for AL amyloid patients, while for ATTR, the 4-year survival is 18 to 42%. So essentially showing that cardiac involvement is the main driver of prognosis, and this was further tested in other studies to validate these staging systems and essentially confirming what was initially thought for both AL and ATTR, as shown here. Now, just talking a little bit about AL amyloid management. On this timeline, you can see how much the therapeutic landscape changed for the disease to the point where we are today essentially relying on chemotherapy and sometimes a stem cell transplant, as I'm going to show you later. And the most commonly used scheme now is daratumumab and CyBorD, as you can see here, essentially since 2020. And there are also other drugs and regimens being tested, so much more yet to come in this field. So as I mentioned, current chemotherapy usually involves the dara-CyBorD scheme, which is composed by cyclophosphamide, bortezomib, dexamethasone, and daratumumab, which is an anti-CD38 monoclonal antibody and the only one approved for treating AL amyloidosis so far. And then stem cell transplant can be delivered in some cases. And of course, that comprehensive supportive care for cardiac involvement or frailty or polyneuropathy is important along this patient's trajectory on top of the specific therapies. And this is actually the Andromeda trial, which is the trial that is the basis on why hematologists prescribe daratumumab for these patients. So you can see that from this trial, when daratumumab was added to the initial scheme, which was composed of CyBorD only, it further reduced death, organ deterioration, and hematologic progression. And interestingly, it also shows that complete hematologic response is more easily achieved if daratumumab is added. So on the right figure, you can see that this was possible in 53% of the patients received daratumumab, whereas for those receiving CyBorD alone, achieved in only 18% of those patients. This is just um, proposed therapeutic scheme with the current management strategies. I'm not going to go into details because I'm a cardiologist, so hematologists will know this much better and its nuances. But essentially, the majority of these patients will receive the DARA CyberD scheme as a starting point. And for those with less than a complete response, stem cell transplant will be considered. And only a minority of these patients will be considered for a stem cell transplant as the initial therapy. Here you can see that stem cell transplant and the DARA-CyberD protocol have been associated with some very good clinical results, with rates of very good partial response above 70%, almost approaching 80% with the DARA-CyberD alone. And then in this scenario, there are some new therapies being tested that hopefully will derive some interesting um, uh, results in the future. So for instance, we have agents being tested that essentially are designed to target misfolded light chains or misfolded serum amyloid A proteins, or even the difficult to degrade formed amyloid fibrils. But however, there are still many unmet needs that not necessarily pertain to targeted agents. Here is just a figure showing what are all the ongoing trials testing new therapies in this field. There is one trial there that was already finished, and that's the one that tested doxycycline, a new drug for with a new purpose. But unfortunately, and I believe it was published last year, unfortunately, the results were not what initially expected, and so no changes with regards to mortality and quality of life were seen when doxycycline was given to these patients. Now we're going to change gears a bit towards the treatment of ATTR, which is completely different, and again tells us that this is actually a completely different disease. So essentially, we have three types of agents that were already tested or are still being tested. So we have one agent that will act on synthesis suppression, here mostly represented by patisiran and inotersen, and those are actually already approved for treating neuropathy, but not for cardiomyopathy. Hopefully we'll have some trials, some trial results over the next couple of years that are testing these drugs in those with cardiomyopathy as well. Then we also have agents acting on TTR stabilization, with tafamidis being the most common agent and approved for cardiomyopathy. And then we have agents to eliminate the amyloid deposits, but those are overall still being tested and so not approved in clinical practice. So here we have a figure showing the main results of the trial that essentially supports the use of tafamidis in patients with ATTR cardiomyopathy, and that is the ATTRACT trial, which was published in 2018. And it really paved the way for tafamidis in the setting of ATTR cardiomyopathy. As you can see, this drug reduces all-cause mortality with a hazard ratio of 70%, so quite significant. A caveat here is that it seems to take around 18 months under treatment for benefits to start being seen. And that is what's showed on this curve. And also rates of cardiovascular hospitalizations were also lower in the tafamidis group, with a relative risk ratio of 0.7% as well. More recently, acoramidis, another TTR stabilizer, was tested, and results of this phase 3 RCT published recently in the New England Journal of Medicine in January this year, as you can see. So it was associated with a reduction in the primary outcome, which was a composite of death from any cause, cardiovascular-related hospitalization, NT-proBNP, and 6 minutes walk test reduction. And it also showed better quality of life assessed by the KCCQ score, and reduction in the serum level of transthyretin, which is essentially a proof of concept finding. So to summarize, the proposed therapeutic alternatives for ATTR are currently tafamidis and now acoramidis for cardiomyopathy. And then for neuropathy, we can add to the arsenal patisiran and inotersen as available options. But again, those were not tested appropriately for cardiomyopathy yet. With regards to future perspectives, as you can see, there are many proposed challenges and opportunities in this field, but I would like to highlight some that I think that might derive interesting research and results in the future. So those would be determining what are the determinants of phenotypic heterogeneity, like for example, what's the role of the gender in that, or what are the modifier genes, or even epigenetics and fiber composition. With regards to diagnosis, populations to screen, what are the populations to screen for cardiac amyloidosis, and optimal screening method, thinking of course on diagnostic yield, but also on sustainability of our healthcare system. What's the role of artificial intelligence to facilitate diagnosis, especially when coupled with imaging, ECG, or multiparametric diagnostic algorithms and calculators. Now, with regards to natural history, I think we need to understand a little bit more definitions and measurements of disease progression and how to relate to that, and then what to do with that if a patient has not responded as good as we wanted. And then in terms of treatment of complications, not necessarily the targeted agents. So for example, is initiation of anticoagulation in patients without atrial fibrillation of value? We have no trial on that. What's the efficacy of proven heart failure drugs in patients with different degrees of heart failure associated with amyloidosis? Efficacy of beta blockers, identification of patients who could benefit from that, role of invasive heart failure monitoring devices, and also patients who would benefit from prophylactic pacemaker, and those who would benefit from ICD and CRT therapy. And then with regards to the specific treatments, we now have new anti-plasma cell therapies being tested for AL, new gene silencers in ATTR. Then who are the patients who would benefit from early initiation of therapy? Definition again of disease progression despite therapy and ATTR, criteria for switching from one drug to another, early identification of responders and non-responders to specific therapies, antibodies to induce removal of tissue amyloid deposits, and I think genetic editing treatments are being tested and hopefully coming in the future. And I think those can make a huge impact for these patients. Now, just mentioning some pitfalls, myeloma with cardiac amyloid. So this can happen due to ATTR, not necessarily AL. So even though not the norm, this can be seen. So just keep that in mind. Misdiagnosis of amyloid type may lead to inappropriate and poorly tolerated chemotherapy. And 30 to 40% of patients with ATTR wild type have unrelated MGUS and cannot use bone scans alone for diagnosis. So using this acronym for MGUS, and with the courtesy of Dr. Dan Judge from the Mayo Clinic, in MGUS, if you're suspecting of concomitant amyloid, you must go under the skin. And then some final remarks. AL may have a slowly progressive course. This is not the norm, but you can see that sometimes. Rare patients may have more than one type of amyloid, which is oftentimes a disaster. Hypotension and autonomic dysfunction might limit use of guideline-directed medical therapy for heart failure, especially beta blockers. So at the same time, this can be a hint for amyloid whenever they're treating a patient with heart failure and they cannot tolerate even low doses of beta blockers. Digoxin should be avoided as can be toxic even with normal serum levels. And that's pretty much it, what I had to talk to you guys today. Hopefully it was useful, and I'm happy to take any questions.
Thank you, Dr. Kern. We have one question from Dr. Sandra Ofori. Their question is, in your practice, how do you monitor treatment response? Frequency of repeat imaging? What is your approach if one therapy is not working? Would you switch therapies or the combination?
Yeah, those are excellent questions. That being said, we don't have robust data in the literature to define what's the best method to say if a patient is responding appropriately or not. I think more often than not, we rely especially on biomarkers, given that echo, for example, can take some time to show reduction in the thickness of the alveoli. So biomarkers and especially clinical response with regards to heart failure symptoms. And what was the other question? Sorry.
If one of the therapies is not working, would you switch therapies or would you switch the combination?
Yeah, so for AL, that's essentially managed by the hematologist. But my understanding is that they will usually start with the Vera CyberD, and then most of the patients will have good response to that, provided they are not in advanced stage. But if they do not respond, they might, if eligible, they might end up going for stem cell transplant, again with good responses after that, provided that the other comorbidities won't limit the performance of the transplant or the outcomes after the transplant. Whereas for ATTR, so far we only have tafamidis approved, maybe acoramidis soon, but those are essentially similar agents as they are from the same drug class. So the option we have is tafamidis. If patients do not respond well to that, which I've never seen, to be honest, once they were started on the drug and deemed eligible, we don't have any other options available at this point in time, unfortunately.
Okay. Do we have any other questions from the group? You can put it in the question comments or the question and A slot. I just have one question as you went through, with heart failure, your symptoms, and we see this as a often chronic hospitalization. Do you have an estimate of the number of patients in which this diagnosis is completely missed?
I don't have that number, but what I can tell you is, again, in patients with, especially those with HFpEF, we know that in a population of all comers with HFpEF, which is the most common presentation actually rather than HFrEF, around 20% of these patients can actually have amyloid. So you'll need to rely on other features to raise the suspicion. But I don't have that number, unfortunately, no.
No. I'm just going to see, is there any other questions? I'm checking for any raised hands in the question bank. If not, thank you very much, Dr. Kern. This was a fantastic talk, and I welcome everybody else to have a wonderful rest of their week and the rest of their Thursday. We'll end today's rounds. Thank you very much.
Thank you. Thank you for the opportunity.